Welcome to the Explainer. Today, we are really digging into something important, a post-hoc analysis from the Codebreak 200 trial. We're going to break down how Sotorasib stacks up against docetaxel for patients with KRAS G12C mutated non-small cell lung cancer, and, more specifically, for those tough-to-treat patients with brain metastases. So let's just jump right in with the big question, the one that this paper is really trying to answer, a challenge I know we all face in the clinic. For this specific group of patients, after they progressed on first-line therapy, what's our game plan for managing CNS disease?
All right, first things first. To really get why these findings matter, let's set the stage and look at the clinical problem this research is trying to solve.
You already know this, but it's worth repeating. CNS involvement is a huge and, frankly, formidable challenge in lung cancer. We're talking about up to 40% of our patients, so this isn't some rare event. It's a common complication that completely changes a patient's prognosis, which makes finding effective brain-penetrant drugs a massive unmet need. Okay, so who are we actually talking about here? This analysis zooms in on a very specific group of patients. These are not your newly diagnosed folks. No, these patients are heavily pretreated. They've already progressed after both platinum chemo and a checkpoint inhibitor. And here's the critical detail. Their brain metastases were already treated and stable at baseline. That piece of context is absolutely essential for interpreting everything that follows.
So with that in mind, let's move on to the evidence itself and see exactly how the Codebreak 200 investigators decided to tackle this question.
You know, it's so important we frame this correctly right from the get-go. This was an exploratory post-hoc analysis. That means these findings are, by definition, hypothesis-generating. They're not definitive proof. We just need to keep that in the back of our minds as we walk through the data. So here are the two arms we're looking at. In one corner, you've got Sotorasib, the oral targeted therapy. And in the other corner, standard of care IV docetaxel. And you can see the numbers for this specific CNS subgroup were pretty small, 40 patients in the Sotorasib arm and 29 getting docetaxel. Now, this is what I find really interesting. When you look at the baseline characteristics for this brain met subgroup, they were remarkably well balanced. You know, despite the small numbers and the post-hoc design, you don't see any glaring differences in age, performance status, or even who got prior whole brain radiation. That gives us a bit more confidence that we're comparing apples to apples here.
All right, this is what we're all here for. Let's get to the core findings. How did Sotorasib actually do inside the brain?
Let's kick things off with the headline result, the key endpoint for this analysis, CNS progression-free survival. And wow, the results here really show a pretty striking difference. Sotorasib more than doubled the median CNS PFS. We're talking 9.6 months compared to just 4.5 months with docetaxel. In a patient population this heavily pretreated, that kind of separation is, well, it's definitely clinically meaningful. The hazard ratio of 0.43 really drives home just how big this benefit was. I mean, that's a 57% reduction in the risk of CNS progression or death. And with a p-value of 0.02, this wasn't just a random finding, right? It was statistically significant. So, delaying progression is one thing. That's great. But did sotorasib actually shrink the tumors that were already there? To figure that out, the study took a closer look at the patients who had measurable lesions, at least 10 millimeters, in the brain at baseline. And the answer seems pretty clear. The rate of significant tumor shrinkage in the brain was 33.3% with sotorasib. That's more than double the 15.4% they saw with docetaxel. So this gives us some real evidence of true intracranial activity. Now, here's the crucial part. These benefits inside the brain didn't seem to come at the cost of some new, unexpected toxicity. The safety profile was exactly what we've come to expect from these two drugs. You know, manageable diarrhea and liver enzyme bumps with sotorasib and myelosuppression with docetaxel. No new safety signals popped up in this particular subgroup. Okay, so let's hit pause and do a bit of a reality check. How does this all fit into our clinical decision-making? It's time to talk about the study's important caveats. And this is a really key point. The authors themselves are very clear about this, and rightly so. We have to interpret these promising results with the appropriate scientific caution, just given the nature of how this analysis was done. So this slide really sums up the limitations we have to consider. First, it was exploratory and post-hoc. Second, the sample size is small. And third, and this is a big one, these patients had treated and stable lesions. This might not be what you'd see in a patient who's showing up with new
or actively progressing brain mets. And finally, CNS imaging wasn't mandatory for everybody, so it's possible some asymptomatic progressions were missed.
So, what's the clinical bottom line here? After we weigh the impressive efficacy against some pretty significant limitations, what should you really take away from this for your practice on Monday morning? Well, I think you can boil it all down to 3 key takeaways. Number 1, in this specific patient population, Sotorasib provides a meaningful CNS benefit over chemotherapy. Number 2, it's not just holding the line. It shows real intracranial activity by actually shrinking lesions. And number 3, it does all of this with a predictable and manageable safety profile.
And we'll end on this final thought. Look, yes, this is a post-hoc analysis, but it's also the most robust randomized data we have so far for Sotorasib's activity inside the brain. And that leaves us with a really compelling question that directly impacts how we sequence treatments for this very challenging group of patients. Thanks for joining this explainer.